Okay, thank you. So yesterday in the talk about genetics, what I tried to do was give a little bit of background and enough information to interpret the kinds of findings that are being published, the kinds of research that's being done. Today, what I'll speak about are more of the clinical considerations for genetic screening. So disclosures are research related, and the outline for this talk, genetic screening, what do we mean by genetic screening? And focusing on something that I'll refer to as red flags, so indicators that you might be looking at something here that's a more genetically mediated kind of scenario, and what to be thinking about. And then what does gene testing sequencing entail? So I showed this figure yesterday, but just as a reminder, we have different kinds of genetic mutations, variants in the sequence, the ACGT that makes up your DNA sequence. And when we're thinking about genetic screening, we're thinking about looking for these things on the left side of the screen here, the low frequency or rare variants in the general population that if you inherit it, there's a high likelihood of inheriting the vascular disease associated with it. So one of the syndromes that we'll talk about is Marfan syndrome all the way on the left, and not the common variants all the way on the right today. So by genetic screening, it's actually a comprehensive assessment, and it starts with a review of your medical history, a 3-generation pedigree, so to get a full family history, including as many relatives as possible. And what that means is the number and age of onset for the affected relatives, how many siblings, if there are multiple, and in which generations they're occurring. That suggests more of a genetic pattern. And a lack of family history doesn't rule out a genetic cause, but in particular for vascular diseases, the family history can be quite helpful. What we're looking for when we're asking about, kind of the screening questions would be, are there any aortic diseases, arterial diagnoses, known connective tissue disorders, sudden death, and are there specific exam and imaging type findings that suggest a connective tissue disorder, one of the disorders that we're going to talk about. The physical exam, imaging findings, and I'm going to go into detail on each of these points. Consideration of possible risk factors. So not having one of these risk factors sort of suggests that there isn't some inciting event that we can attribute a SCAD event to possibly, and maybe think more about genetics or some kind of inherent predisposition, predisposing somebody to having a dissection. And then finally, gene testing. So when I think of genetic screening, I'm thinking about all of these things and not just a gene test in isolation. So this is just generally kind of a teaching slide for genetic red flags. This is not particular to SCAD, but I think some of these, they all kind of are worth keeping in mind. Generally what we're thinking about for red flags are family history of multiple affected family members, earlier age of onset, if the condition is occurring for SCAD in men, so the less often affected sex would make us think about a genetic etiology a bit more. The absence of some risk factors, ethnic predisposition in this disorder for SCAD is not something that I think there's something in particular that we would have a red flag around. If there's close biological relationship between parents, what that suggests is more likelihood of inheriting low-frequency rare alleles for autosomal recessive, where you need 2 copies of the gene. Most of the vascular conditions that we're looking at are autosomal dominant, meaning you need 1 copy of the genetic mutation to express the disease. So the differential diagnosis of the genetically mediated arteriopathies that we really don't want to miss, as Dr. Wood laid out yesterday, and I talked about a little bit in my talk, are Marfan syndrome, Loeys-Dietz, vascular Ehlers-Danlos, and a few others that are listed here as well, polycystic kidney disease, other thoracic aortic aneurysm and dissection conditions, TAAD or thoracic aneurysm and dissection tends to be genetically mediated more than other types of aortic disease. And things to keep in mind are that the diseases can become manifest at any age, and that even where there is the same mutation in an individual within a family, the disease itself may vary quite a bit. So in families with Marfan syndrome, for example, one individual may have a very severe young onset presentation, and other family members may have just a very mild version of the disease. So what I wanted to do is go through each of these in some detail so that you can get a sense for how these diagnoses are made. There are some very, very helpful online tools. So the National Marfan Foundation has a website where all of these criteria are listed, and there's a score sheet that I'll show you where to go. So this isn't something you need to necessarily memorize, but know what these features are. And the key pieces are family history, aortic root dilation, which is calculated as what's called a Z-score, and I'll explain that more in a subsequent slide, and dislocation of the lens in the eye, which may not be something that is clinically apparent and may actually require an ophthalmology exam to appropriately assess with a dilated exam to see if the lens is actually dislocated from its normal position. And it's because the fibers that are holding onto the lens are made of the same connective tissue type proteins that are in the arterial wall. And so you can see that whether you have a family history or not, there are some different criteria. One of the other main features is your scoring on a systemic score sheet. So the key tip-offs are tall stature, the appearance of the face, the fingers, chest wall deformities, and some of these imaging-based findings. So these are the key things. This is the Z-score, which is something that I calculate in every patient that I'm evaluating for SCAD. When you get an echo, there's a measurement across the aortic sinus, which is right where the aorta takes off from the heart. And based on distributions that have been developed for body size, sex, age, there are different values that have been developed. And a Z-score greater than 2.0 is abnormal. And that should be a red flag for Marfan syndrome and for Loeys-Dietz. The systemic score is based here. So what's very interesting about the vascular connective tissue disorders is that it's not any one thing, really. It's a whole set of characteristics that you put together, and it's a pattern that you're able to put together. So this is the actual score and the numbers you get, and greater than 7 is a flag for Marfan syndrome. And you can see that some of these are things that you can assess on an exam. You can ask folks if they can move their thumbs in certain ways, what their elbow extension looks like, and some of these are things that you need to actually do by imaging. So dural ectasia is some abnormalities of the dural layer around the spine, and you need imaging to determine that. So these are some of the features of Marfan syndrome, and what you can see is the reduced elbow extension, the elongated fingers, arachnodactyly. There are several facial features as well that have to do with where the chin is placed, how developed are the cheekbones, and these are part of the criteria along with tall stature. This is whether the thumbs go over to the side, and whether you can wrap your fingers around and cover up your pinky and your thumb. So pretty simple maneuvers that take a few minutes to do in a clinical exam room, but if you know what these criteria are, you can be looking for them. For vascular Ehlers-Danlos syndrome, there are some things that are very key features. So arterial ruptures, intestinal uterine ruptures, so rupture of a hollow organ, extensive bruising. There's a description of a characteristic facial appearance with thin lips, small chin, thin nose, large eyes, but it's not very specific. I would say for vascular Ehlers-Danlos, this is due to mutations in collagen 3A1. This is one that there can be really not very much on your exam and the screening. But certainly if you see these features that are described here, it should serve as a red flag. Loeys-Dietz syndrome is due to mutations in the pathway of genes that are involved in the TGF-beta signaling pathway. TGF-beta has a number of different kinds of effects throughout the body, including how the connective tissue comes together. It's in general a fibrosis pathway, so whether there's additional fibrosis in the vascular tissue, making it more fragile in certain ways. So this is a syndrome with premature and aggressive aneurysms, dissections. There can be some facial features. One of the red flags would be a uvula that has 2 parts on it, 2 lobes, instead of a single lobe coming down. Arterial tortuosity, so when you image the head and neck vessels, these are patients who may have complete loops in their carotids, a lot of tortuosity. And the degree of tortuosity probably means something clinically. There's a vertebral tortuosity index that's been associated with the rates of aortic dissection. And again, like I mentioned, the aortic root size is key to monitor here. And with Loeys-Dietz syndrome, there can be aortic events, ruptures, dissections at smaller dimensions. So the thresholds for surgery are different. And so a molecular diagnosis of Loeys-Dietz versus Marfan syndrome can be very helpful. Okay, so the workup then, clinically, in addition to the clinical pieces, the evaluation, family history, in terms of testing that I think about is the brain to pelvis CTA or MRA, looking for vascular involvement. So we're often doing this looking for FMD, but if you see multiple arteries with dissections, like one of the cases that was presented this morning, that might make us think about some of these Loeys-Dietz vascular Ehlers-Danlos that can be associated with dissection of multiple arteries. On the echo, we're looking for mitral valve prolapse and the aortic root size, as I mentioned. Mitral valve prolapse suggesting more Marfan type picture. We evaluate for hypermobility, and I'll show you on the next slide what that Beighton score actually is. We look for the skin, we look for scars that are somewhat separated and have what's called a cigarette paper appearance. That's called an atrophic scar and suggests that the extracellular matrix is a bit abnormal, and we see that often in many of the connective tissue disorders, Ehlers-Danlos being one of the key ones. We talked about the systemic score, the ophthalmology evaluation, and sometimes there are metabolic conditions to think about, so you might check a homocysteine level. This is more for aortic dissection and not been associated specifically with SCAD. But this is kind of the general approach to somebody with an arteriopathy that you think might be genetically mediated. So Beighton score, this is looking for hypermobility of small joints and some of the major joints, and it's whether the elbows extend past 10 degrees, the knees hyperextend, whether you can get your thumb to touch your forearm, whether the small joints are hyperflexible, and whether from a standing position you can put your hands flat on the floor. And there are age-related norms for each of these. So a woman in her 50s, if she has a Beighton score of 5, 6, 7, 8, or 9, that's elevated and suggests one of the vascular connective tissue disorders. So as far as gene tests, these are the current kind of targeted sequencing panels. So if you look to send off a test where you're ordering a clinical test that you can check the box and get, what you're typically ordering are one of these approaches. There are multiple companies that do this. These are just the two most common that we've been using recently. There's multiple factors for which company gets used more at a specific time, including some issues around feasibility and cost and things that don't have to do with the quality of the data necessarily. But what you'll see is the collagen 3A1 is represented in both. There are some other earlier Danlos genes, collagen 5A1, collagen 5A2. Fibrillin 1 is for Marfan syndrome, and then the bottom row is all of these Loeys-Dietz genes. And I made the point yesterday, but just wanted to emphasize that even when we are doing an evaluation for what looks like a very strong inherited pattern of arterial disease, like a thoracic aortic aneurysm and dissection in a family, our pickup rate is rather incomplete, meaning that we might do these gene tests, they come back negative, and we're still thinking that this is a genetically mediated problem, but it's not falling into one of these categories that we're finding. So that's important. When we get these results back, I'm always very eager to see what the collagen 3A1 report is. If it's negative, if the Loeys-Dietz is negative, that's very reassuring that we're not dealing with one of these pictures if there aren't other clinical features going for that. Sometimes we do have situations where we're very, very suspicious for vascular Ehlers-Danlos or for Loeys-Dietz, and if the test comes back negative, we still proceed with additional testing that we can do. Each of these tests have their sort of weak spots and strong spots, but in general, these sequencing features are going to be pretty good, and a negative result is very reassuring. On the flip side, we don't do this in everybody. There's kind of things happening in the fields of genetics where there's something between clinically mediated and a specific question you're trying to answer. And you might see here that even when we're not suspicious for Marfan syndrome, it's on the panel. So we get back information about fibrillin 1. And often what we end up with are sort of these gray zone results called variants of uncertain significance, where it's something that's a bit too frequent in the population or doesn't damage the protein as much as we think it should. And we end up categorizing those as something that's not normal, but probably not the reason for a disease. And as research continues, I think we'll continue to see evolution of these gene panels. For the last few years, there's been a gene added to these panels every few months from the research of aortic diseases, and hopefully in the future there will be genes that we think are specific enough that we can be testing for SCAD. There is not currently a specific test that I would say is for SCAD, but you can see that there are sometimes indications to do testing to make sure we're not missing one of these rare syndromes. So in general, genetic evaluation is useful to establish a diagnosis, to identify potential associated medical problems that may need evaluation or treatment that are outside of the vascular tree. So for example, on the Marfan syndrome page, what you saw, there was pneumothorax, there were other things outside of the vessels. There's the eye problems, those things need sometimes specialized evaluations and treatments. And a genetics group can be helpful with deciding which tests are appropriate and helping to interpret the results. I think that's a really key piece, the interpretation of results once you get them back. And then to provide counseling about recurrence risk for other family members. This is sometimes referred to as cascade screening, where if you find a genetic variant that is pathogenic by all of the criteria, then this becomes a very specific, useful tool to use as a test in family members who may be affected or unaffected. So in summary, the way that I've defined genetic screening, including not just the genetic testing, but more the clinical evaluation and all of the pieces that you get together from the imaging, I do think that this is worth considering for every patient with SCAD. Decisions about sequencing of specific genes is based on that comprehensive assessment. Our ability to diagnose genetic causes of SCAD is definitely evolving. I think we're in a sort of upward tick right now with regards to the kinds of research that's being done, and what we've seen from the aortic disease field is it's been very fruitful to identify new genes. And the role of common genetic variation, I've emphasized that isn't specific enough to tell you about your own personal risk today, but there may be in the future ways that common variants can be put together across multiple sites to figure out, do you have enough of these to maybe put you at risk? And those would be still a ways off in the future, but things that we could be looking for as developments of the research. So the benefits of early diagnosis are enhanced surveillance, medical management. There might be things we tailor according to the gene that's involved. And overall, I would suggest, engaging specialists in SCAD or cardiovascular genetics, or if needed, medical genetics, to do that initial screening and to make sure that one of these less frequent syndromes in which SCAD can present is the case here. And just as future directions, multiple groups are doing research. We're looking into the genetics. Our group has been focused on family-based genetics, and we're just across the hall enrolling individuals who are interested in participating in families. We're always happy to be contacted.
Thank you.